Welcome to Duke Spine Institute's live stream of spine surgery. Our patient is a nurse. She is a nurse. And she came to Duke Spine Institute, like many nurses, because she's having horrible pain in her spine, in her case, thoracic spine, and she wants to get rid of it. She knows we're the best in the world at eliminating spine pain, minimally invasive, with minimal chance of complications. Now, she has 3 herniated discs in her thoracic spine. We're going to go fix all 3. T7-8, 8, 9, 9, 10. All right, I'm using a marker, and let's see, I got to find the 12th rib. So let's go down a smidgen, Jordan. Just there it is. All right, now show us L1. You guys see T12, L1? L1, Ariana, is the first vertebral body. That's a pedicle that does not have a rib. So there's no rib on that body. Then you go up to 12. You can see the rib, Ariana. See the rib there? Coming back and connecting to the circle, which is the pedicle. So that must be T12. Then go up 1, 11, 10, 9, 8, 7. So my marker is at 7, 8. All right? 7, 8. So 7, 8, and then 8, 9, 9, 10. So let's go down to 9, 10 shot. A little bit lower shot. All right, so that's 9, 10 there, correct? 12, 11, 10, 9. So we're doing those discs. We're going to probably need to make 2 incisions. Now, can we get a good picture of her lung fields before we get started, please? I'm going to do an injection local. Oh, she's a little bit too light, Dr. B. Let's make her a little bit deeper. All right, we're going to zoom out, get a lung field view. Jordan, let's get that done. Bigger. I want to see the full lung field. Let's go. I think you're going, well, the right way. Should be the right way. All right. Can you do a little bit more? If you have questions, feel free to ask us. Go all the way down. Is that as far as you can go? Table up, up, up. Perfect. Shot. All right, I think that looks pretty damn good, huh? And we're on the right side. Good. Looks good. Let's go back. If you have questions, feel free to ask. In the meantime, I'm going to get started. We are doing a right-sided transforaminal endoscopic annular debridement, aka Duke laser disc repair, to treat her pain in her thoracic spine. I want to try if we can. I'd like to. So that's 12, 11, 10, 9, 8, 7. I'm going to start with 7, 8, right? Everybody agree, 7, 8? All right, if you have questions, feel free to ask. Shot. All right, so 12, 11, 10, 9, 8, 7. I'm heading right for 7, 8. Shot. Shot. Let's see. Shot. Let's go with a lateral view. We're going to alternate between front, back, and side views. I'm lined up nicely. 12, 11, 10, 9, 8, 7, 7, 8. Everyone agree 7, 8? That's the first top disc we want to do. You can see on the lateral view. We're still pretty far away from that disc, so I've got to get closer to the spine. I'm going to come back a little bit, redirect shot. It's going very well so far for her. Shot. All right, she has a little bit of osteopenia. Let's get the orbit right. I think we're off on orbit. You see the double shadow at the back of the vertebral body? You saw it, right? I think that's kind of hard to tell. It's not terrible. I think that's better right there, right? Do you agree? Good. All right, show us the disc. That's better. Show us the disc. There's the disc. The white arrow showing you the disc. Show us the back of the disc. There's the back of the disc. Show us those two little nipples right there. Right there. You're right below them. 1 and 2, right next to each other. Those are actually opposite sides of the vertebral body. So the fact that they're so close together means that we are very close on our orbital view, which is good. That's what we want. All right, you can see the needle is right at the back of the disc. I'm about to enter the disc, and that's what we want to do. And it feels so far, everything is going good, shot? All right. This is the most difficult surgery I do, by the way, for those of you wondering, shot. And AP. If there's questions, feel free to ask. In the meantime, we're not going to show the 30 causes of back pain because it doesn't apply. All right, let's verify levels. So I see L1, 12, 11, 10, 9, 8, 7. 7, 8. We are at 7, 8. Everyone agrees? 7, 8. That's the first disc we're treating. I agree. Let's go back to a lateral view. We're about to enter 7, 8. Any questions?
At this moment, no current questions.
All right. The first time I did this surgery was on a patient who was suffering with horrible thoracic pain. And he got 100% pain relief after the surgery, literally 100%. Shot, we're inside the disc. Perfect. Next, I'm going to go for needle number 2 for the next disc. Shot. Probably need to be a little bit lower. Shot. All right, line up that disc for me nicely, Jordan. Shot. Once you have the 7, 8, which is the top disc, the other discs you can actually count them down because they're right below the first one. So getting the first one is very important in terms of numbering. Shot. Oh yeah, very nice. Shot. All right, we're way over penetrated. We need to reduce the penetration on the x-ray. It's too white. I can't see detail. Shot. I think we're off on orbit. Let's try to fix the orbit. I can't say that's better. I think that's worse. Show the double shadow for people. Okay, that's fine. I think that's probably better. All right, now let's fix the WAG so we can look down the disc so the end plates are perfectly parallel. I think you got to fix the WAG a little bit. Oh yeah, that's perfect. Now what we're doing, folks, is we're adjusting the fluoro like this is called WAG, and like this. This is called orbit. So we're adjusting the fluoro in 2 different planes to get a perfect shot down the disc. You can see the needle is right at the back of the disc. Let's go ahead and do an AP view again. Any questions?
At this moment, no current questions.
All right. If you have thoracic pain, you should see Duke Spine and let us evaluate you on our free Zoom appointment. We give you 10 minutes for free and figure out what's wrong. I'm looking at the lung fields. I don't see any pneumothorax. Pneumothorax is one of the potential complications of this surgery. That's a dropped lung. We've never had a pneumothorax. I don't want to have one today, but that is certainly a possibility. And patients are aware of that risk, and they're willing to do the surgery. All right, Dr. B, we're almost ready to do our discogram, but she is a little bit lighter than I want her to be. All right, a little bit of local for the skin. We're almost done, folks. We're going to place 3 needles. We're fixing 3 discs. All right, you're doing great. Just lay still. You're okay. So once again, our patient is a nurse who's had thoracic pain for 3 years. Thank you, Sam. 3 years of pain.
Caused her to stop working as a nurse.
She had to stop working as a nurse. She was all over the hospital, right? I mean, she had a lot of different jobs. I just need her asleep for like literally 5 minutes to get this in, and then we'll do the discogram. Lay still, you're doing great. Everything's okay. Any questions while we're waiting?
At this moment, no current
Sean?
questions.
All right, so I got one more disc to get. I think for some reason this is definitely going to, it's a good thing she did all three, because she was contemplating not doing all three, and I was contemplating not doing all three actually. I thought maybe we could just do the one and get everything we needed to get, but I was wrong because her pain is indeed coming from all three. Sean? We're going to verify that shortly. All right, you can see the tip of my needle by the facet. Shot. AP. Any questions?
No current questions, but we do have a comment coming from, it's a very long name, but we're going to go with SSS Super Auto on YouTube.
SSS Super Bio?
Super Auto.
Super Auto. Okay, very good, Super Auto. Nice to meet you.
Saying genius at work.
Oh, thank you so much. I appreciate it. I don't know. I don't see myself as a genius, but that's okay. Thank you. Thank you very much. All right. So you can see the two needles in the two discs, 7, 8, 8, 9. We're going for the 9, 10, which is the bottom disc that we're fixing today. We're just about there. And so far she's doing amazing. Yep, we're there. All right, I'm going in. Shot. Hold on. A little bit of resistance. I'm going to just double check my AP view, make sure I'm in the right spot. It looks great on the lateral view. Let's just do a quick AP. This is the kind of surgery you want to be checking, double checking, triple checking, quadruple checking, then make sure you're in the right spot. It's so important because the spinal cord is right there. We're so close to her spinal cord, we don't want to damage it. I need 1 minute, I'll be ready for her if you can. And if you can't, that's fine too. Yeah, there it is. We're there. We're there. You saw it. You saw it. Folks, we're going to try to do a discogram. If I can get this discogram, it will be amazing. To do the discogram allows me to confirm what I diagnosed based on her MRI and her clinical appearance. Is she ready? A few minutes.
For me? I'm going to ask you some questions, okay?
So what you're seeing are needles that I placed very carefully from the side through the foramen into the disc right where the herniation and tear is in the back of the disc. That's our target. We want to clean up that tear with the laser, get rid of the herniation. Now, she showed me my back pain is here in this area right here, okay? Right in here. And hey, you're doing great. It's Dr. Duke. Just hang in there. So I want to verify now that indeed that's where her pain is from. So this is T910. 910. This is T89. Nobody else in the world can do this surgery, by the way. Literally, we're the only ones that offer it. Thank God we do, because people's lives are miserable when living in this pain. And I pioneered the thoracic transforaminal endoscopic surgery. All right, you okay? You having any pain?
Doing okay? We're going to ask you a few questions.
You having any pain?
Are you in pain right now? Are you okay?
Huh? All right. Well, let's see if we can do this. Shot. All right, there's the tear in the back of the disc. You guys see that tear? Now the thoracic is not going to have the same disc structure as lumbar or cervical. It's different. It's transitory, transitioning between lumbar and cervical. We might come back and try again in a minute. Shot. I think she's responding to that one. Definitely. You see the dye coming out through the tear. Let's keep our blood pressure down. Yeah. All right. Huh? All right. Well. Oh yeah, look at her moving. I'm just putting a little bit of pressure at the bottom one. That's the one she marked as the worst. All right, let's go ahead and put her to sleep. We're going to move forward. I got a positive response for all 3 discs, but no number. So I would say concordant, but no number. Unfortunately, with thoracic, we have to make 3 little incisions. I can't do it all through one incision. So each incision will be a 4 millimeter incision, enough to accommodate the scope and the sheath or tube around the scope. We're going to start with the bottom one.
Which one is that one?
Why not? Shot. If you have questions, feel free to ask. We place the guide wire. Now we're going to remove the needle and leave the guide wire. By the way, this whole surgery is being done with our patient under sedation. There is no tube. There is no general anesthesia. This is a sedation, conscious sedation type surgery. 4 millimeter incision. Now I'm going to place the dilator. Look how small this dilator is. There's no cutting with this dilator. It's literally just less than 4 millimeters. You have another one?
Yeah. Take it out of the set of tubing from the cervical.
Is that still sterile or not?
That's still sterile, but you can put it on.
Are you going to use it?
No.
Here?
Yeah, you can put it. Yep.
Can you address that? You guys ready? You guys see this dilator?
Yes, we do.
See how tiny the tip is? Let's get a tape measure here. I'm going to show you how small this is, folks. I know it's hard to appreciate. Here's millimeters. The very tip of it is literally just 1.5 millimeters. So this is why we don't have any pain after the surgery, because the incision is so small and the dilator doesn't do any damage. It just spreads the muscle fibers and fascia. It spreads it apart. We're going to head into the disc. Shot. This poor patient, she's a nurse. She's been out of work for years because she can't work. She's in too much pain. Every time she tries to help a patient, lift a patient, move a patient, it throws her back out. And we see this all the time. Shot? All right, so I need to get down to the spine. Shot. Blood pressure is good. Yeah. Shot. Shot. AP. Let's just check an AP real quick just to be sure. Yeah. When the blood pressure was up, that's perfect. Bleeding. You understand? Now it's not. All right. Very good. Perfect. Looking good. We're going to advance this dilator into the disc. Any questions?
Yes, we have about 2 questions. This next one is coming from Steven on YouTube,
Shot? I'll take Stephen's question.
asking, my quote was for all 3 thoracic, left and right. Is this possible?
All 3 thoracic, left and right. Is it possible? I mean, I don't know what you're asking me, Stephen. Are you asking if we can do the surgery? Or are you asking if the quote was for all three?
My guessing is that can you do 3 thoracic discs left and right, like bilateral?
We can. It's going to be a long surgery, but we can do that, yes. I prefer to break it up, but I honestly don't remember your situation. But we don't recommend something we can't do. All right. Here we go. So that's good. We're in. We've got the tube in. Now I'm going to go in with the endoscope and laser and repair this tear. All right. Any questions for me?
Yes. Before the question, we have a follow-up comment from Stephen saying, only because you said you didn't want to do all 3 of hers. Oh. All right. Well, given that. Anyways, next question is coming from...
Well,
yes.
Yeah, Stephen, my advice is if we've seen you, recommended treatment, just talk to your scheduler rather than try to ask me about your particular surgery on a live stream while I'm operating on another person. All right, laser on. The schedulers know exactly what can and can't be done and what should and should be done. So, all right.
Next question is coming from Lanu on YouTube,
Hi, Lanu. Welcome.
saying arthritis question. Can removing herniated pieces reduce the spread of arthritis?
Yes. That's what we do with the Duke laser disc repair. We're removing the herniated pieces that are stuck within the annular tear causing arthritis. So by removing the herniated pieces of disc within the annular tear, by treating it with laser, we're reducing the spread of arthritis. Absolutely. All right, let's see a grabber. Once again, this is a nurse who is unable to work because she's in so much pain. And she came to Duke Spine to get help. And turns out her pain was coming from what are called disc herniations in her thoracic spine. And so here we are repairing those disc herniations, specifically coming from the tear in the back of the disc at T7-T10, T8-9, T9-10. And that's what we're working on. We love our nurses.
We have a couple more questions.
Sure.
Next one from Lanu once more on YouTube. A question for me asking, are you also responsible for podcasts at Duke Spine Institute? The interviews with various of people were nice to watch. Thank you. Yes, I am responsible, but Dr. Duke and I, we partner up with that on the video ideas and structuring of the podcast episodes and all that. And then,
Henry is definitely responsible. He's the one who put together the podcast.
Yeah,
Right
I set it
way.
up. I was the one who uploaded it and everything, and so. But when it comes to the video ideas, Dr. Duke and I, we
There's just
go
not
into that
enough
together.
laser energy being delivered here, Luis.
Do you want higher, or do you want?
I think higher.
Whenever he stops.
Grabber.
Right now, increase the power, please. Yes. Thank you.
Just bring it up. Bring it up. Bring it up.
Thank you.
That sounds fine. I'm just not seeing the effect of the laser like I normally do, so.
Better?
It seems to be a little better. I mean, there are other factors like how much scar tissue is here, but mhm. Yeah, right now it's 25. Normally 20, right? I would bring another fiber here just in case.
We have a couple more questions.
Sure, just ask him, Henry. You
Of
don't
course,
need to.
not a worry. Coming
And
from
then go ahead and play one of our videos.
copy that. Coming from Faisal on once more on Facebook, saying, "Hi, doctor. You're doing a great job. Regarding thoracic disc herniations, what's this patient's symptoms? And due to the fact they were in the spine, these discs are. Can they inspire organ functions to the nerves that are being irritated to the heart, lungs, etc.? Thank you."
So the patient's symptoms are back pain, thoracic pain, right around the bra strap. That is typically what people get when they have a herniated disc in the thoracic spine, is dorsalgia, which is axial pain radiating from the disc out to the back. Sometimes it radiates around the ribs. In her case, she has no radiation. It's just back pain. With activities, it gets worse. So it's a mechanical back pain, and it's coming from her disc. Pretty typical disc type pain. Yeah, we need a new fiber.
Can you open the box, please? Yeah, thank you.
Next is a comment coming from Lord Impaler on YouTube, saying, "I sent my 2 CDs out for my neck and my lumbar. Hopefully you got them. Natalie is amazing. I got L3, 4, and 5 for lumbar, C4, 5, and 6 coming from New York. I'm going to make WCP take care of it. Cannot wait."
All right, great. Yeah, we like Natalie. She does a great job with the MRI review. If you know somebody who's suffering with back or neck pain, feel free to get a free MRI review with Duke Spine Institute. We offer this service to everybody in the world. It doesn't matter whether you come and treat here or not. We do it for free because we want people to know what's wrong with their back and neck, and we want them to know that we can fix it for them when we can fix it for them.
Next,
Which is pretty much every time, but we just have to know what the cause of the pain is. To do that, I have to do the MRI review.
Make it will be a roll one, please.
these next few questions are coming from Pon Lust on YouTube,
Pawnlust? Okay, sure.
asking, "Hi, Dr. Duke.
Hi.
T8, T9 doesn't seem to have a noticeable herniation. Are you mainly trying to close a tear? Also, I read that thoracic discs have much less height than lumbar. How do you manage to fit the tube inside?"
Yeah, so people are always looking at disc herniations, looking for something big. And that big herniation, in their mind, justifies that the disc is the cause of pain, but that's wrong. We know the disc is the cause of pain because it's abnormal on the MRI. You don't need a big herniation. Herniation size has nothing to do with how much back pain somebody has. Back pain has to do with the fact that there's an annular tear and there's inflammation. So all we have to establish is that there's an annular tear and that there's inflammation in the disc. You can see that on the MRI. And you have to verify that's where the patient's pain is coming from, which we've done clinically. So that's how we determine this disc is the source of pain. We like to verify that with a discogram, but we don't always get to do that. Turn.
Follow-up question from Pon Lust once more on YouTube, asking, "How does the disc have space to allow it in that space?"
I'm not really sure I understand the question.
Yeah. If we can find any specificity towards that question, we'll be happy to answer it. Till then, next comment is coming from Lord Impaler once more on YouTube, saying, I've pretty much been told over 20 years, over 20 people about this place. I cannot wait.
Thank you. Thank you very much. Appreciate that. We are doing some special things here, fixing people's pain, especially thoracic. This is the rarest type of surgery we do. It's also the hardest. So there's not a lot of people. Look at, there's a piece of herniation. You guys see that? Just floated out.
Yes, we do.
There's a lot of that in this disc. This disc was injured a long time ago. I can tell because there's a lot of scar tissue, this white stuff here, very thick, very difficult to remove with the laser. Normally a young herniation within a few years is blue and it's soft and it's easy to remove. This thing is like really hard crab meat, you know, chunks of crab meat. And it's just sitting here not wanting to come out. So, but yeah, thoracic pain, very uncommon, but it does happen. And when it happens, thank God there's people that can fix it now. This pain can be so bad that the people who suffer from thoracic disc herniation pain, they just try to get up and do stuff and they can't because their back hurts every time. And that's how she was. Constant pain in her thoracic in this area right here that we're operating on. Any other questions?
At this moment, no current questions. So in the meantime, why don't we show the audience of how it is that herniated disc causes thoracic pain?
Sure.
Disc injuries start with an annular tear, damaged nucleus. Pulposis herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
Welcome back. You can see from our video how the disc herniation causes thoracic pain through an annular tear. And these little fragments are what's floating up. Those are pieces of herniation coming up. Trying to get rid of them. Great questions so far from our audience.
Indeed.
Any other questions I can answer? Each of these is pieces of loose herniation that you guys are seeing right there.
Yes, we coming back from Pawn Lust once more on YouTube, reiterating, how does the disc have space to allow it in the tube?
Oh. Well, the discs are bigger than the tube. The tube itself is 4 millimeters, so it's skinny. And the disc itself is usually a good 10 millimeters, at least. That's why.
No current questions, so we do have a comment coming from Lord Impaler once more on YouTube saying, so I had a total of 3 lumbar surgeries on L3, 4, and 5, and now I'm reherniated again. And the only option I got is to be fused. It's giving me no other option. In for my cervical, he wants to disc rep. I think that means for his doctor.
Yeah, you do not need a fusion. We can fix your pain without a fusion. 100%. I'm sure of it. You just need to come to Duke Spine and get a proper treatment. We used to do fusions all the time, but we learned how to replace fusions with laser. All right. And our plasma rhizotomy. Just depends on the source of your pain. I don't know. I feel like we're overexposed a little bit on this. It's just a little bit too much light. Yeah, that is better. You guys see the inflammatory tissue there, the red stuff?
Yes, we do.
The laser is, well, the problem is the more scarred up the herniation is, like full of scar tissue, the more laser energy you need in order to remove it. Does that make sense? So this herniation is massively inflamed and scarred from years and years and years. This is not a new herniation. This is an old herniation. Flip it. And that's why you're seeing the laser. Your head is right in the way, Luis. You're seeing the laser not as effective as it should be, as you want it to be. It just means we have to spend more time. The laser will still work. It's just going to take more energy, more time to remove these pieces of herniation that are causing her symptoms. And to say we're removing herniation, that's not entirely true. We're doing what's called a debridement. In medicine, a debridement is where you remove abnormal tissue to allow healing. So that's really what we're doing. So when I say we're removing herniation, it's more than that. We're removing inflammatory tissue, scar tissue, calcium, abnormal pain nerves, and herniation, all of those things from this area. I got about 2 minutes left on this particular disc, and then we're going to move on to the next one. Any other questions?
Yes, this next question, or we have a comment and a question. This comment is coming from Faisal once more on Facebook,
Sure.
saying, "Doctor, I wish Hulk Hogan knew about you.
Oh, I know, right?
He said he had around 30 back surgeries in his lifetime. Maybe that
Yep.
contributed to his passing."
Yeah, I 100% agree with you. I wish Hulk Hogan did know about us. That's the problem. People don't know about us. That's why we do our videos. But we don't have a lot of money to market. We're not a big marketing company. He went to Laser Spine Institute in Tampa, and he had surgery there. I would never go there. They are not the same as us. We do better surgery than Laser Spine Institute. They were drilling holes in people's spines, and I'm sure they put holes in Hulk Hogan's spine. So I don't recommend their treatments. All right, we're pretty much done. You can see the last of the inflammatory tissue, the last of the herniation right here, and we're done. You see the pink color? There it is. We just got it out. All right, so we're done with one. We're going to move on to the next, but I got to put some antibiotics in here. So far, she's doing really good. Her blood pressure is good. She's asleep. She's stable. Her vitals are stable. Oh, let me have it back. She's doing awesome. Where's my suction, guys? I have no suction. What happened? Yeah, it's full. Full will do that. Thank you. That's a nice suction right there. Great job. Great job with the suction. Come on, come on. All right. There's one. Let's put that over there. I'm going to staple this incision. You guys see how small it is? It's 4 millimeters. It's tiny. I'm just going to put a staple or two here. All done. That's one down, 2 more to go. All right, let me show the audience. Go ahead, Jordan, come in. Let me show the audience the endoscope so you guys can see what I'm using. Not right now. You see this, Henry?
Yes, we do.
You got a camera, you got an endoscope, light source, laser, irrigation, and also suction. All right, where do you want this, Luis? You want it here? Okay, there you go. We're going to go for disc number 2. Let me have the guide wire, please. Now, I'll say that surgery is a team effort. It requires everybody to do their job properly at the same time, okay? You guys are watching a surgeon, but you're not seeing the anesthesiologist. The anesthesiologist is working just as hard as me, keeping the patient stable and alive. You're not seeing the technicians like Jordan and the nurse, the circulating nurse, doing her job, okay? but everybody is working constantly, including Luis, even though Luis looks like he's just on vacation. All right? Thanks, Nikki. The point I'm trying to make is there's, 8 people in the operating room, including the patient, and 7 of us are working our butts off. 1 of us is sleeping. And the fact is, we need everybody doing their job properly to keep this patient safe and alive. And when a team member, for example, if they were to say, get on their phone and get on TikTok or something in the middle of surgery instead of doing their job, the patient's going to end up suffering. Right, Dr. Berndes? Shot? Is that it? All right. I'm trying to advance the dilator in. And typically, if you're, distracted with social media on your phone, and you're not helping the team take care of the patient, there could be problems. So that's why it's very important that everybody is doing their job and doing it all the time. Otherwise, it puts our patient at risk of complication. Any questions?
Yes, we do. We have a couple of questions. This next one is coming from the classic car nut on
Shot.
YouTube.
Oh, my good friend.
Yeah. Good to hear from you. Asking, hi, how common is pulmonary embolism risk with DLDR versus traditional methods? And also, when is this movie coming out? Thank you.
Ha! All right, so classic car nut, thanks for coming and being classic. So first of all, pulmonary embolism is extremely unlikely with Duke laser disc repair. Why do people get pulmonary embolism? Pulmonary embolism is a blood clot that forms in your calf, in the veins of your calf or your arm, and then it dislodges and goes to your lungs and stops the circulation in your lungs, and basically you die from that. It is common, more common in surgeries that are invasive, like fusions, or joint surgeries like hip surgery, but it's very rare, laser on, in minimally invasive procedures like the Duke laser disc repair. Is it on? All right. So our patients have never had pulmonary embolism. It would be extremely rare. I've never seen it happen in my patients. I think I had 1 patient in my entire career, the last 20 years, that got a pulmonary embolism. And they were a fusion who had complications, not from me, but they had prior surgery with oh, look at that herniation right there. You guys see that?
Yes, we do.
It's like a little spider crab trying to climb out of the tube. Anyway, so it's never happened with a Duke laser disc repair. You're not going to get a pulmonary embolism because our patients are back on their feet right away, back to a normal life by the next day, driving, shopping, cooking, walking, whatever you do. It's people who lay around in bed in pain all day because they had major surgery that's painful, like fusion. Those people are the ones who get pulmonary embolism, okay? As far as the movie goes, it was going to take another year for Netflix to evaluate the movie and then buy it. And we decided I didn't want to wait another year, so we're just going to release the movie on Monday. You guys can watch our movie Monday. Spine Scam will be released Monday for the world to see, right, Henry?
Yes, sir. We have it ready to go, all ready to go on our new channel, the Spine Scam, the movie channel. And yeah, all is well with that.
So you can watch the movie Spine Scam that we produced here at Duke Spine on Monday on our YouTube channel called Spine Scam Movie.
The movie, correct.
It's free. There's no charge. We decided the best way to get the movie out to everybody around the world is to do it for free and not make them have to pay for a streamer's subscription. So YouTube is free, right?
Yes, it is, of course.
By the way, we're not even doing advertisements on the movie. It's literally advertisement free, or should be, at least. And we're not making any money on the movie. It's just educating the public about the horrors of invasive spine surgery and the companies that promote it for their own profit and their own well-being rather than yours. Great to hear from you, Classic. We're about halfway done. We fixed one disc completely. That was T910. We're fixing the second disc right now. The laser is working much better on this disc. You guys see that? See how much more effective the laser is on a newer piece of herniation, like this stuff right here? It really gets rid of it so easily. Whereas the old scarred up stuff is much harder for the laser to work on. And that last disc that we did was old and scarred up. Old scarred up disc. Hey Luis, help me out here. I'm disconnected. Any questions?
Yes, we have a question coming from Pawn Lust once more on YouTube, asking, so a posterior annular tear was listed on her MRI. Asking that, I think I have several thoracic discs like hers after some injuries. Some of the bulges / protrusions shrunk, but there's still axial back pain. It's not severe pain anymore, but it is still chronic that goes higher with activity. It's amazing to see this kind of surgery, and I hope she gets a great result. For her age, her discs aren't as generated as I would have guessed either. The height is decent.
Yeah, I think Pawn Lust, you're bringing up a really good point. A lot of people believe as we get older, our discs degenerate. Why is my... Fuck. Can somebody come look over here? I think this bag is leaking. I'm feeling my entire shoe is wet. Come on, get a light over here. You can't see it. You don't have Superman eyes. You got to get light.
The soccer still on?
Yeah, the soccer. It's just dipping low.
What?
The top of the bed. It's dipping low.
So where's the source of the water leaking on my sneakers? Is it possible to rectify the situation? Another piece, look at that piece of herniation, guys. Huge. I'm gonna have to grab it out. So the fact is, everybody thinks that degenerated discs, herniated discs, happen with age. They don't happen with age. They happen with trauma. If you can be 95 years old and have perfectly normal discs if you didn't have trauma to your discs in your lifetime. Okay? So it's not age that causes degeneration, it's trauma. So if you've protected your spine and you have strong discs, healthy discs, then when you're 95, you're going to have normal looking discs. I've seen 15-year-olds with degenerated discs. I've seen 95-year-olds with normal discs. Okay? It has nothing to do with age. It has to do with injury. Oh, grab her. What is it?
Just the way it's like dripping out.
Well, let's try to fix it so it's not. Blood pressure. Burned us. We can. All right, I didn't ask your opinion. I need somebody who can fix the problem, not somebody who can criticize and doesn't know what they're talking about. No, you're not. You have no clue what you're doing. Did you?
It's just down in the front, the top of the bed. Everything is connected.
All right. Where is it down in the front?
Just like over here, the way it's dripping, it was on your.
So it was dripping over the front lip.
Correct.
Why would it drip over the front lip?
The way you were leaning on it, I guess.
Huh? Come on over here. Come on over here. Turn on the light. Why would it drip? What is this right here? That's a suction line. it doesn't let it fill up. It literally sucks it out. So why would it overflow the front lip if it's being sucked? No, you can lean on it. There's a sponge. Anyway, any other questions from our audience?
Yes, we have a question coming from Mike on YouTube
Sure.
asking if you have central disc spur osteophytes at C5, C6 extending to the cord midline, can you remove it?
Yes, we can remove it with laser. That was an easy one, Mike. Thanks.
And at this moment, no current questions. So in the meantime, why don't we show the audience of how it is that we cure thoracic disc pain?
I think that's a great idea, Henry.
Disc injuries are a common cause of chronic thoracic back pain. The inflamed annular tear causes thoracic back pain. A 1/4-inch size skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website at www.dukespine.com or call us at 1-800-FIX-MY-BACK, 349-6922.
What's the issue? All right. Feel free to ask questions. We're almost done with disc number 2. And we're going to move on to disc number 3 next. Flip it. And just working upside down, right side up, debriding this tear in the annulus. You guys see that? As we pull the tube back, we get more of the tear. We do more debridement, clean it up, and then we pull it back a little bit more and just keep working it that way. So we're working from the inside of the disc herniation to the outside. We're starting in the inside. She's moving a little bit. We call it the inside out technique. This is probably the more sensitive part of her disc. That's why she's responding. But she's not awake. She's still asleep. But kind of like if somebody were to take a pair of pliers and pinch your toe while you're sleeping, you're going to move around a little bit. We call that reflexive movement. Reflexive movement is normal. How is she doing? She's doing good. Yeah, this is probably the more painful disc. Remember the middle disc? That was the more painful one of the 3 that we tested. I think her bottom 2 are the more painful ones. It's interesting because if you look at the MRI, I would have said the top one, based on the MRI, I would have said that was the most painful one, but I would be wrong. You cannot look at the MRI to tell which is the most painful. You have to basically ask the patient, they'll tell you where the most painful is. In her case, it's this one. All right, just about done. Let's see here. Thank you. Any other questions?
No current questions, but we do have a comment coming from the classic Car Nut once more on YouTube, saying, when you, Dr. Duke, confront your team on an issue, it shows how much you care about your patients.
I do. I want my patients to have the perfect experience, to have a great result, to not have any complications. So, unfortunately, I can only do so much, but there are things happening in the operating room but that other people are controlling. Like I said, there are 6 other people right now working on things, and if they do their job right, then there's no issues, no problems. But if they make a mistake, then unfortunately things start going sideways. I've got to identify that and fix it quickly. But I got great people here, and honestly, there's very little issues that we have. And part of that's because we got great people. The other part is because we do the same surgeries over and over again. So we're actually have everybody kind of accustomed to these types of surgeries, to where they're able to execute their tasks over and over again, like doing the same thing over and over again every day. And you get pretty good at it, to where you don't really have much deviation. And then if you have a deviation, you can identify it quickly and deal with it quickly, right? Fix it, So we've gotten really good people here, and they're very accustomed to the equipment and the circumstances of doing these surgeries, to the point that they can identify deviations quickly and fix them before they become really a problem for the patient. So very, very fortunate in so many ways. There's a piece of herniation, by the way, for those of you wondering. That's what it looks like. Remember, that tube is 4 millimeters wide on the outside, 2.8 millimeters wide on the inside. So that herniation you just saw, that looks big, but it's not big. It's about 2.8 millimeters wide. So it's really kind of small. But you don't need big to make pain. Small things cause pain. How's she doing? All right. Just about done. I'm just at the, I don't know, I'm losing it again. It's disconnected. We have a little fluid adapter that connects to the tube. There we go. And as I'm moving the fluid adapter up to come out of the disc, it keeps disconnecting. So we're having to reconnect it. This is the outside of the tear right here. This is probably the last millimeter or 2 of the tear. And you can see how much scar tissue is here from chronic inflammation. And I just keep going back and forth, just taking my time. That's how you do it. There's no fast way to fix these tears. You guys see the tear? It's pretty obvious right now. Right there, top to bottom. And I want to clean out any herniation I can in this tear so that it'll close. You guys see that?
Yes, we do.
To me, it's looking pretty good right now. Any other questions?
At this moment, no current questions.
You got 1 minute on this tear, and then we're done. 1 minute, and then we'll move on to the last one. So people said, isn't your surgery just discectomy? But it's not. Discectomy means you're taking the disc out. Discectomy, ectomy means to remove. We're not removing a disc. We're not touching the disc. We're just dealing with the tear. All right, that's looking pretty damn good right there. A little bit of inflammatory tissue on the outside, but we are now pretty much in the epidural space, right around the spinal cord. Spinal cord is going to be at the 6 o'clock position. Still a little bit of too much scar tissue here. You guys see that?
Yes, we do.
You can see an epidural vein right there to the right, just outside the retractor, right there. All right, we're pretty much done here. As a matter of fact, you guys see the tear is almost completely closed. It just got to seal itself. All right, so just because it's opposed doesn't mean it's sealed. Okay, we're done with that. One more disc to go. Little antibiotics. All of this is being done endoscopic spine surgery. That's what you're watching. Thank you. Any other questions?
At this moment, no current questions.
Once again, for those of you joining us late, she's a nurse. She's been a nurse for many, many years, but she had to stop nursing because she couldn't work anymore. Her back was hurting too much. And the pain was right where these herniations are. And that's why we're doing the surgery today. We're doing the surgery to get rid of her thoracic pain. Dr. B? Yeah. All right. You guys see the incision? 4 millimeters, it's tiny. That's what endoscopic spine surgery is. It's minimally invasive. There's no cutting of any muscle or bone or ligaments. It's literally preserves the integrity of everything but the skin. You're just cutting the skin. That's it. Can't do surgery without cutting skin. But once you cut the skin, we're not damaging anything else. All right. Last one. Use an 11 blade. And this is a tiny incision, 4 millimeters. Let's get the blood pressure down. Her blood pressure is not very high, but I like to keep it very, very much normal or slightly below normal. Shot. All right, here we go. Last one. Thank you, Jordan. I'm going to wait a minute. Berndes? Huh? Oh, you did? Not for the blood pressure, but she's wiggling a little. Okay, good. Thank you. Any questions?
At this moment, no current
Shot?
questions.
Uh-huh. Seems brutal, you know, banging a metal dilator into someone's spine, but it's very safe as long as it's done properly. Here's the whole tube we're doing the surgery through. That's it, the whole tube. It is literally 4 millimeters wide. And this is the last disc we're going to be doing. Disc number 3. Go ahead. Shot. So far, so good. Perfect. All right. Once again, for this young lady, we did 7, 8, 8, 9, 9, 10, thoracic. This is endoscopic transforaminal Duke laser disc repair. Our cure rate for back pain coming from the actual disc, not the facet, but the disc, is 99%. That's 1 year after the patient's had surgery. We asked the patients on average, 1 year post-op, how much of your pain did we get rid of? And the answer was 99%. We have very low sluggish flow. Sluggish flow of the irrigation. Can you guys look at that? Huh? Let's pay attention to that. All right, any questions? There we go. It looks better now. Thank you.
Yes, we have a question coming from Mike once more on YouTube,
All right, Mike, happy to take your question.
asking if
Flip it.
a cervical disc is very degenerative and cannot take the dye from the discogram, can you still remove all the scarred up painful material?
Yes. Yeah, we can. Mike, the problem is not your degenerated disc. The problem is the wall of the disc, the annular tear. Okay? That's the problem. Everybody thinks collapsed disc can't fix with laser. Yes, we can. Degenerated disc can't fix with laser. Yes, we can. There is no disc pain or problem we cannot fix with a laser except for ankylosing spondylitis and ossification of the posterior longitudinal ligament, OPLL. Okay? Those are two conditions. They're both very rare, but they do happen, and the laser surgery is not appropriate for either of them. We also can't fix a fracture. No, it's not the right surgery if you have a fracture. If you have a tumor in your spine, not the right surgery. The laser will not work. Infection of your spine. It could work. We do treat discitis. All right, we can clean out your infection in your disc. There's a herniation. But if you have pain in your spine, you want to talk to Duke Spine Institute. That's what we cure. Back pain, neck pain, thoracic pain. We've got it down to a science. It works every single time. Now, if we fix one source of pain, you may have another pop up. We can't predict that, but that does happen. Okay, some people have disc pain, we fix it, then they have facet pain. Or we fix the disc pain and facet pain, they have their piriformis muscle starts hurting. So a lot of times people develop pain in other areas and we can fix them, but if we don't know about them, we can't fix them. All right, we got 10 minutes max here, Dr. B.
We have another question
Sure.
coming from Charlie on YouTube,
Once again, I'm getting... Sure, Charlie on YouTube.
asking, is there any endoscopic posterior / dorsal approach you feel can be successful for cervical decompression, both central and foraminal?
A little too much movement of the patient. There is no... there is a posterior cervical laminectomy, foraminotomy you can do. Usually we do that with a fusion. But I wouldn't do it endoscopically. I would do it open. I wouldn't recommend it. That's like saying you can fish. The best way to fish is with a net, but can we use sticks of dynamite instead? Sure. Why would you want to use sticks of dynamite when you can use a net and you're going to catch the fish? More fish with a net, you're going to keep them alive. They're not going to be blown to bits. So why would you want to do a posterior approach when it's like taking a stick of dynamite to the ocean and blowing up a whole reef? It makes no sense. Just because somebody tells you to do that doesn't mean you should do it. Just because somebody tells you that's the only way they know how to fish doesn't mean you should let them fish that way. That's why we put these videos out there. The very best treatment is the endoscopic for cervical disc herniation. There's nothing better. And it's through the front, not the back. And it's the Duke laser disc repair. That is the very best. Everything else is worse. Worse for you, the patient, not worse for the surgeon. Remember, the more invasive the surgery, the better it is for the surgeon, usually. And the hospital. They get more money. But the worse it is for you, the patient. What is it? Luis, put a blue towel there. Keep it from closing. Right?
Yes.
Why not put a blue towel? It seems like a simple solution. You have blue towels available? You're not using them. All right, we're just about finished. I've got 5 more minutes left on this disc. See the grabber? There's a piece of herniation right there. You guys see that? Does not want to come up and out. It wants to stay there. So I have to go in and grab it out. Are you not understanding the whole blue towel concept? All right, look. If for some reason this is going like this, okay, look. If this is being compressed here, what does that create? A seal, right? Okay. This blocks the seal, but if you roll it, it makes a seal, and the water just travels right on down the outside of the bag. So how could you avoid that? You take a blue towel, and you put it here, right where the seal is being broken. You see that? Now, it doesn't matter if you compress it, the water is going to go into the towel, below the towel, and down into the bag. It will not come onto my feet. I don't understand why why a neurosurgeon has to stop the surgery to explain these things to you guys. I've got to have you guys like my co-pilot. You guys got to be solving problems and not making me solve these problems, because I have to fly the plane. Okay? I got to drop the bombs on the target or whatever it is I'm doing that takes my attention. I can't have to stop what I do to solve little problems that you guys should be able to solve. Yeah, her muscle tone is increased, which is fine because we're almost done, but normally it creates a bit of a challenge for me to do her.
I think she's just at a sensitive part of the disc.
Yeah, I understand. But I have to fight her more, the more awake she is. That said, we're almost done, so it's fine. Right below the tear surface at this point. Any questions, Henry?
At this moment, no current questions.
All right. All right, this is probably one of the last few pieces of herniation stuck in the tear here. We're releasing it. Here it comes. Remember, these herniations, they get scarred down, stuck down to the wall of the disc through a process of what's called chronic inflammation. Chronic means it's been going on for years. Inflammation, we all know what that is. It's like having a pimple on your face that doesn't go away for 10 years. And it's going to cause scarring. Everybody knows that, right? Everybody knows that if you have inflammation in your skin from a pimple for a long time, it creates pits in your skin. If you look at the face, it's got all these craters. Those craters are scar tissue. They're scar tissue because the inflammation was never put out. It was just left to go. Let it go as long as it wants, you know? And people get these scars on their skin from that inflammation happening and nobody's stopping it. So same thing happens in the disc. You let the inflammation go for years, then you get scar tissue in the disc, right in the wall of the disc. And that's what we're dealing with. So these herniations, they don't want to come out. They want to stay here. They're stuck down. Like, that's what the laser does. It releases them. You can't get rid of the herniations that are stuck down without the laser. It just doesn't work. That's why when people tell me, why can't you do the surgery without laser? It's impossible to do it right. You can do surgery without a laser, but you can't do it right without a laser. You're not going to get a good result. That's like saying, why don't you use a wrench to hammer in a nail? Well, what's wrong with using a hammer, right? Why would you want to use an inferior tool? Hammer is designed to hammer. Wrench is designed to wrench. Why use a wrench as a hammer? That said, I've used a wrench as a hammer many times. Right? We've all done it. Who wants to go back to the toolbox in the garage and get the hammer when you can use your wrench? All right. Got about 2 minutes left, 2 minutes left. And Jordan will do a quick AP x-ray looking at the lung fields. All right, my man, get that x-ray ready. How's your ventilation? Good?
Good. Sats are 100.
All right, sats are 100. That's great. All right, just about done. There's the end right there. Look at that inflammatory tissue. You guys saw the pink stuff? That's what causes all the pain. Remember, pink is bad when it comes to herniated discs. Pink is bad. Pink is bad. I'm not talking about the group, the artist formerly known as Pink. I'm talking about the color pink. It means inflammation, and we don't want to see it. Right, Luis? We don't want to see it. You know a movie I watched the other day? An oldie. Django. Anybody see Django? I'm not talking about the Django with Leonardo DiCaprio. I'm talking about the original Django.
I've seen it. Yeah.
Great movie, huh? You saw that?
It's good. I see the influence of where the new one with Tarantino one's influenced by.
Where what?
I see where Tarantino got his influence from that. It makes like
Yeah.
yeah, and then the original Django in that was in Tarantino's Django.
Yeah. Yep. The original Django. That's what I watched. I haven't watched the Tarantino one in a while. It's been a few years, but it is good. Look at that inflammatory tissue. Flip it. All right, we're pretty much done. Last few touches here, and we're finished. Do you guys see the tear right there? We just got through debriding it. You can see down into the depths of the disc.
Yes, we do. We do have another question.
Look at that pink stuff. Just about finished. Yes, I'll take the question, and we're going to wrap it up, my friends, and then we'll be back for a... What, the next case is going into room 2?
Yes, sir.
That's a facet. And then we'll come back for a piriformis. Is that what it is? Piriformis SI? Yeah? I'll take the question.
Coming from Mike once more on YouTube asking if you have degenerative herniated L5 to S1 and have painful numb feet, can you fix it? I bring my knees to my chest and I feel a little better.
Well, if you bring your knees to your chest, Mike, then what you're doing is opening up your neuroforamen, so you're decompressing the nerve roots. What that tells me is that your symptoms are due to spinal stenosis, which, yes, we can fix it. But if your symptoms were due to diabetic neuropathy or neuropathy, which also causes burning in the feet, then no, I can't fix it. So it's going to be real important to get a nerve test just to make 100% sure that we're able to fix it, okay? Grab her. But from what you're describing, it sounds like we can fix it. Man, this disc is just hard. Oh, looks like I got it. Yeah, good. All right, this is it. We're outside the disc. Final touches here. Final touches on the debridement. And it's been a really good surgery for this young lady. She's a nurse. Remember, look at all that inflammation. You guys see it all? That's where the most inflammation is. She is a nurse, and I'm hoping that when she heals up, she can go back to being a nurse again. She loves her job, loves being a nurse. And we love our nurses, don't we, Luis? Sometimes a little too much. Huh?
We have another question
Yes.
coming from Frank on YouTube,
Yes, Frank on YouTube.
asking Dr. Duke, can you ask Dr. Berndes if he has tried berberine? If he hasn't, tell him to try berberine.
Burberry.
Tell
Yeah.
him to look it up.
He can hear you. Burberry. He's looking, he's listening. His ears have perked up. He says he takes it all the time. He says he takes it twice a day. It makes him regular. Just kidding. I don't know what Burberry is. Isn't that like a clothing store?
Lowers blood sugar and it's great for weight loss.
Hi. He says it lowers blood sugar and allows weight loss.
Oh,
Burberry.
it's glucose support.
Who's that asking?
Frank.
Thanks, Frank. All right, guys, we're done. That's the end of it. Great. Thanks for being with us. I'll just show you guys the incision one last time. We had to make 3 because I couldn't get them all done with 1 or 2. So 3 little 4mm cuts. She's going to go home in an hour. This is not in the hospital. This is outpatient. Our surgeries are all outpatient. And our patients do not need pain medicine after surgery for their surgery. So no narcotic painkillers. Just some Tylenol or Advil, and that's it. All right, we'll be back in about an hour with another surgery, which will be a pretty quick one. Any other questions?
At this moment, no current questions. Just a comment from Frank saying it works beautifully.
Thank you.
The berberine.
Burberry. All right, very good. Thanks, everybody. We'll see you all in an hour.